Hi, everyone. Welcome to today's recording on clinical anatomy of the lungs and pleura. Hopefully, this short presentation will take you through the important content that you need to know to understand your lectures, to do well during your tutorials, including specimens and imaging, as well as to understand some of the important clinical correlates that may come up during your exam at the end of the year. So let's get started. Before we even talk about pleura and the lungs, it's important to understand what pleural membranes even are and why should we care about them in the first place. When we say pleural membranes, it comes under the general umbrella term of a serous membrane. And in terms of the pleura itself, they are serous membranes that line each of the lungs. So you've got two of them, and you've got it lining the thoracic cavity. When I say serous membrane, I'm talking about a simple squamous cell mesothelium supported by connective tissue. So literally a single layer of epithelium that is supported by connective tissue. Now, in your body, you will grow to learn that there are actually three main serous membranes. You've already looked at the serous membrane of the heart, known as the pericardium. Today, we're going to be focusing on the one for the lungs, which is the pleura. And in a couple of weeks' time, you'll be looking at the abdomen. And in that case, it's called the peritoneum. It's important to remember that most of the time, these layers actually will be continuous with each other. So we're not talking about three separate things. They're actually the same. It's just that they're named differently based on the location in which they're found. When we talk about serous membranes, though, they all have a common anatomy to them. So you've got an outer layer, you've got an inner layer, and then you've got a space in between them that's filled with fluid. The outside layer we call the parietal layer, and that covers the cavity wall. So in the case of the lungs, we're talking about the thoracic cavity. With the visceral layer, as the name suggests, it's on the inside and it covers the organ or the viscera itself. And between them, you've got the lubricating fluid. Importantly, it's really important to understand that both of these layers are not separate. They're actually the same sheet that's been folded onto itself. So the example that is given in the lectures and is usually referred to in textbooks is if you take a little balloon like this or a squishy bag and you were to punch it really hard, you'll notice that while the original expanded balloon had only one outer border, when I punch it, I end up with one outer layer on the outside, which we would in this case call the parietal layer. And the thing or the layer that's touching my fist, and in this case, you could say the fist is the organ, that would actually be the visceral layer. But as you can see, there are points at which the visceral layer reflects or turns into the parietal layer, and then the parietal layer reflects back into the visceral layer. So it's really, really important concept to understand. Now, why do we have these in the first place? Well, it ensures that organs within a single body cavity can move around without rubbing against each other, causing friction and causing damage. So in the case of the thorax, we wouldn't want the lungs to vibrate or frictionate against each other. And we wouldn't want the lungs to frictionate against the heart and so on. So we've got pleura and serous membranes pretty much everywhere to ensure that that doesn't happen. Also, it ensures that we can breathe without having too much effort. If there was friction, it would take a lot of effort for us to breathe in. It would probably cause a little bit of pain. But because we've got this fluid in there, it means that it's almost like a frictionless material against which we are breathing. So it's really, really important that we have these in all parts of our body. So now that we have an understanding about the serous membranes, let's look at the specific pleura that we have for the lungs. So the parietal and visceral pleura, remember that they are from the same sheet. The parietal pleura covers the internal surface of the thoracic cavity. So it's right up against the ribs and some of the thoracic cage muscles. You've got four main parts to it, and that's illustrated really well with this diagram here. And it's been color coded for you, but remember this is in 3 dimensions. So the mediastinal layer is the most medial part. It covers the lateral aspect of the mediastinum meaning the space between the two lungs, and it's found centrally, as I said. Cervical part is also known as the cupola. It lines the extension of the pleural, that should say cavity, not activity, and it goes right up into the neck. And we'll see that this represents a vulnerable space for penetrating injuries. The costal side, as the name suggests, will be pushed up against the ribs, the cartilages, and the intercostal muscles, and it's on the lateral aspect of the lungs. Finally, the diaphragmatic, again, as the name suggests, will be up against the superior or thoracic surface of the diaphragm. So as you can see, if I want to describe exactly where, for example, some pathology is located on the parietal pleura, I have some really nice terms that I can use to make sure that someone knows exactly where it's found. The visceral pleura is a bit more simple. So it basically covers the lungs. And if you were to look at a dissection, it's kind of like this glossy surface right on top of the lung parenchyma, and it's virtually inseparable. So you wouldn't really be able to remove it as you might with the parietal pleura. Because it's inseparable, it extends directly into the interlobular fissures. In other words, all the fissures that you might find on the lung lobes, and we'll go into the lobes and the fissures a little bit later, but we'll go right into them deeper and deeper, which is why it's so difficult for us to separate it from the lung itself. It is also continuous. So both of these layers are continuous with each other at the hilum of the lungs. So the hilum, again, we will go into a little bit later, but that's the point at which the lung connects with the main bronchi, as well as some other structures. At the pulmonary ligament, which is a lot easier and better to see in dissections, but if you want to see on a diagram, say, for example, this would be the right lung. So in this diagram, it would be this lung here. If I was to look at the medial side and looking out towards the lateral side, this would be the hilum, so where the bronchi connects with the lung. If you go a little bit lower, you will see the pulmonary ligament. And again, it's very difficult to see this and understand why this is a reflection between the parietal and visceral pleura without seeing it in 3D. But you can imagine that this would be the place. It's kind of like a collar on your shirt. It kind of just comes down a little bit, and that just represents the reflection. So whenever someone asks you, like, where are the parietal pleura and visceral pleura continuous, you will always say the pulmonary ligaments. Now, speaking of those cavities and reflections, it's really important to understand that between the visceral and parietal pleura, I mentioned there should be a space with fluid, but we call this a potential space. And the reason why I say that is because it should only contain a very, very small amount of the serous fluid. What does the serous fluid do? It lubricates the pleura to allow smooth sliding between the surfaces. So you don't want the visceral and parietal pleura to rub against each other. If they do, then we get some inflammation known as pleuritis. That'll come later. It also creates a bit of surface tension. And the way that I like to think about this is if you have two glass slides and you put like a drop or a couple of drops of water between them, that's some surface tension so that both of the visceral and parietal pleura kind of stick to each other. Why is that important? The parietal pleura is attached to the thoracic wall, which will expand and deflate with breathing. And you kind of also want the lungs to be synchronized with this movement. So when my thorax expands, I also want my lungs to expand so that I can take in as much oxygen as I can. And that surface tension really helps with that process. However, when I have pneumothorax, in other words, say, for example, I've got a puncture to one of my lungs or a puncture to the thoracic wall, what will happen is because I've just introduced a bunch of air into this space between the visceral and parietal pleura, the surface tension will be reduced or virtually disappears. And now when the thorax expands, the lung is not able to do that at the same time. So it causes the lungs to collapse, known as lung collapse. The pleural reflections are really, really low yield. It's just a good idea to know that they exist and you will be fine. They're places where the parietal pleura abruptly changes direction as it passes from one wall of the pleural cavity to another. Now, in my notes that I will put up on the Google Drive, I've put a bit more detail in terms of what these reflections are. But honestly, if you read it once and you read it twice, you'll be okay. You'll never be asked the specifics of how that works. You can kind of see a artistic interpretation of what each of these reflections looks like in color-coded fashion. And you've also got this diagram here to show you in 3 dimensions. Now, this is probably the most clinically relevant thing that you will need to know. So when you see a patient, it's a good idea to understand, like, I know what the lungs are, but I need to also know whereabouts would the lungs be on the patient themselves. So for example, if I want to listen to their lung sounds, I need to know where the lungs are, especially the different parts of the lungs, so I can hear for consolidations, fluid, etc. So how do we find the lungs? Well, one way is through surface landmarks. And it's a really, really simple pattern that you need to remember when it comes to figuring out what those landmarks are. So with the visceral pleura, when I say, I might just go into these mnemonics first. So when I say MCL, MAL, and MSL, the first one refers to the midclavicular line. So if I've got my clavicles here, if I just find the midpoint of the clavicle and draw a vertical line down through my entire body, through the thorax, that would be the midclavicular line. Mid-axillary line, as the name suggests, so we've got the axilla here, you would have learned in upper limb last year. If I was to draw a line kind of down the side of my body, that would be the MAL. Mid-scapular line is the same thing as the MCL, but it's on the back. So in this case, think about the scapula, have a midway point. It's really arbitrary, but a middle of the scapula, and draw a vertical line again, and that's your mid-scapular line. So that describes your like vertical coordinates. When it comes to the horizontal coordinates, we use the ribs. So for the visceral pleura, you've got rib 6 at the MCL. So you'll need to actually palpate for the ribs, figure out what rib number 6 is, and then be at the MCL. At the MAL, it's rib 8, and at the MSL, it's rib 10. The parietal pleura is exactly the same thing. It's just 2 levels down. So rib 8, rib 10, and rib 12. So as long as you remember the numbers 6, 8, 10, and then 8, 10, 12, you'll be all fine. And of course, remember that the parietal pleura is larger than, or actually encompasses, the visceral pleura because it's the one that's surrounding the thoracic wall. And of course, between these, you're going to find the pleural cavity and by extension, the fluid within it. The pleural recesses are places where the lungs, or in other words, the visceral pleura, will not completely fill the pleural cavity. So where we might expect to find that fluid. There are 3 main places that you'll need to know. Not really 3 because some of these are paired, but 3 main areas that, or words that you should be familiar with. The most important one would be the costodiaphragmatic, and we sometimes refer to these as the angles when you look at them on X-ray. This is between the costal and diaphragmatic reflections. If you have a blunted costophrenic angle, which we might have in a couple of slides' time, that is generally pathognomonic for pleural effusion. And the reason why is when you're sitting up, all that fluid is going to go down to the most dependent or the lowest areas inside your thoracic cavity. And that will be all the way down here. As you can see with my arrow, on the left and right-hand side, you've got those recesses or angles. Costomediastinal is sort of less important. You can see that on the left and right-hand side, on the mediastinal surfaces, you've got little, I guess, thin strips where the pleural cavity is not completely filled up. So you can see that it's highlighted in the blue. It's between the mediastinal and costal pleura. It's directly behind the sternum, which means it's going to be mostly well protected, except for potentially the cupolars, so the parts that come above the first rib, where you have risk of being of penetrating injury. The cardiac notch is only one-sided, so it's only on the left-hand side. As we know, the heart sort of points in the left direction. And the reason why this is so important is because if you have a look here, the lung sort of, I guess, moves around or accommodates for the heart tissue. And so if I know where this is, if I want to do pericardiocentesis, in other words, I need to drain fluid from the heart or be able to sample fluid that's around the heart, I know that it's going to be around the 5th or 6th intercostal space, just parasternally, where I'll be able to get to the heart without actually hitting either of the lungs. So why is this all important? Well, essentially, you don't want to be hitting the lungs because you're going to cause lung collapse, which is never good. So as long as you know where these recesses are, that's a really, really good start. And they'll be used for a lot of procedures as well as imaging techniques. The innervation of the pleura is quite unique just because it's not going to be consistent between the visceral and parietal pleura. And this actually affects how we sense pain in each of these pleura. So the visceral pleura is innervated by the sympathetic trunk and the vagus nerves, which we call the pulmonary plexus. The parietal pleura receives innervation from both the phrenic and intercostal nerves. Now, why is this important? Well, because a lot of these are, sympathetic, parasympathetic innervations, you're not going to really get that much like proper pain sensation. It'll be mainly stretch. And that's useful because your body wants to know, when have I stretched out my lungs too much? And when do I need to now deflate? Or when are my lungs not stretched at all and they need to open up to take more oxygen? That's the main purpose of these signals for the visceral pleura that are surrounding the lungs. So if I have pain or if I have some sort of damage on the visceral pleura, that pain is going to be really non-specific. We call it dull, diffuse, poorly localized. So I'm not really going to be able to tell exactly where that pathology lies if the patient were to describe it to me. For the parietal pleura, however, you've got the phrenic and intercostal nerves, more like the somatic nerves. So the intercostals, as the name says, it's really, really easy to remember which one goes to which. Because we've got intercostal, that's in the rib region. So it's going to be around the outside. That's going to be the costal surfaces of the lungs, as well as the peripheral diaphragmatic. All right, apologies for the interruption. I just restarted the recording. Where were we? So we were just discussing the innervation of the pleura. I already mentioned that the visceral pleura is only responsive to stretch, so pain will be dull, diffuse, poorly localized. When it comes to the parietal pleura, because you've got somatic nerve innervations, it's going to be responsible for detecting pain and temperature. So those really sharp sort of C fibers. So in this case, pain will be sharp and generally quite well localized. So if a patient tells you they're feeling pain around this region or this region, they point somewhere, then you can hedge your bets on the fact that it's probably a parietal pleura problem rather than a visceral pleura problem. It's also important to differentiate the intercostal nerves versus the phrenic nerves and what they innervate. Super easy to remember. So intercostals, they go around the outside ribs. So it's going to be the costal borders of the pleura, as well as the outside bit of the diaphragmatic pleura, which is the peripheral aspect. Phrenic nerve takes everything else. So it's going to be the mediastinal half and the central bit of the diaphragm. And you may remember the course of the phrenic nerve sort of goes around the middle. So that can be an easy way to remember that. In terms of how this is relevant, so as I said, clinically, if someone points to or tells you that they're feeling pain in a specific area, you can map it onto a specific aspect of the parietal pleura. Of course, it's not going to be visceral pleura because that's really dull and diffuse. So if someone says that they've got around T1 dermatome pain, which is the medial aspect of the arm, if you remember back to dermatomes of the arm, remember you go like C4, C5, C6, C7, C8, and then T1 sort of around this side. If they say that, then that's the T1 intercostal nerve, and that's higher up. So we're thinking that's a cervical parietal pleura problem. It's really difficult to say those three words together. Anyways, T2 to T10 intercostals. So that's around the chest area, so upper chest to sort of almost up to the abdomen, or central chest region. That's going to be the costal aspect, and we know that it's going to be the intercostal nerves as well, so that makes sense. Then we go to the mediastinal pleura. If we have a problem there, we know that that's the mediastinal pleura is a phrenic nerve. And you may remember back to embryology from semester 2 last year. We know that phrenic nerve is kind of pulled with the diaphragm, which originates around the neck and shoulder region. So we're thinking if we've got a mediastinal problem, phrenic nerve irritation, that's going to be the tip of the shoulder, the jaw, and the neck. That's going to be where you feel most of that pain referral. If you don't remember that, review some of the slides from cardiovascular anatomy. And then diaphragmatic, because it's got this dual innervation. If it's the central half of the diaphragm, we're thinking more phrenic nerve pain referral, so shoulder, jaw, neck. If it's the peripheral aspect, then we're thinking intercostal nerve problems. All right. Now let's go to the lungs themselves. So let's dissect away all the pleura. We've assumed we've taken off the parietal visceral pleura. Now we're actually up to the lung parenchyma. At least when I started revising the lungs, or when I had this intuitive idea about what the lungs were, I always imagined them to be quite smooth and really really not that studded with things on it. But when you actually look at the lungs in dissection, you'll realize that they're very coarse and they've got a lot of impressions on their sides. So if I start from the very beginning, just really basics, remember the mediastinum is in the middle of your chest. If you look at the left-hand side and the right-hand side, that's going to be where your lungs are. And the medial surfaces tend to be squashed against a lot of these major structures that also traverse the thorax, maybe going from the head and neck, up to the head and neck, or things that are going from the thorax down to the abdomen, or things that are just within the thorax region. So namely, if you're thinking about, it's really easy, you don't have to memorize these, just remember what things you will find on the left versus on the right. If you look at the left lung, you'll notice that, yes, you've got the impression of the heart. And we talked about the cardiac notch because of the fact that the lung sort of, moves away to accommodate for this apex of the heart. So we've got the heart impression. You've got the arch of the aorta. So that comes across here, and you can see it kind of makes an indent in the lung. And of course, that continues on as the thoracic and then the abdominal aorta. So what was really cool is you'll be able to actually see when you pick up a lung in dissection, if possible, you will see that there's a really nice curve on the medial aspect. And that's going to be the arch of the aorta and the thoracic aorta. And then you'll also have the esophagus that sort of just goes midline. Right lung is exactly the same thing. So esophagus, again, midline. You've got the heart, not as much of the heart forming an impression on it, but at least a little bit of it. So this would be the right atrium. Then you've got the IVC and SVC. So you can't really see those here really well. Maybe that's the SVC back there. The IVC comes from the bottom. Again, you'll be able to see that impression on the lung. And then you've got the azygous vein that will come through as well. It's a bit smaller, so it might be more difficult to see. A couple of words that is just good for you to know when it comes to tutorials. In a similar way to how the heart has an apex, a base, and things like that. With the lungs, you've got a couple more words to remember. Really, really easy though. So apex would just be the top pointy bit. That's the part that goes into the neck and is vulnerable. The base is the part that touches the diaphragm, and it physically does touch the diaphragm. So it's really important to be aware of that relationship. You've also got the lobes, which we'll go into in the next slide. You've got two or three of them depending on the lung that you're working with, and they're separated by fissures, which you can get a bit of a demo of in this diagram. Surfaces wise, they just correspond to the area of the thorax that they're facing. So you've got the mediastinal, you've got the diaphragmatic, you've got costal surfaces, really low yield, just know that those terms exist. And then even more low yield is the borders. So you've got three edges. Think about your lungs being sort of like three, like triangles, I guess. You've got anterior, superior, and posterior borders. Again, if you want to have a look at that in more detail, the notes are linked on the drive. So the kind of the deal breaker, or the thing that kind of made me question everything that I've learned, is the fact that the left and right lungs are actually not the same when you think about them anatomically. So they're not, it's not like they're symmetrical across the midline. In fact, the left lung is actually a little bit smaller than the right lung. And if you think about it, it really makes sense, because on the left-hand side, you've got more of the heart pushing in. So you've got less of the actual lung parenchyma to work with. Whereas on the right-hand side, you've got a lot more lung. Just to be a bit more specific, the left lung has two lobes. So you've got a superior lobe and an inferior lobe, whereas the right lung has three lobes. So superior, middle, and inferior lobes. If you want to simplify this a bit and just like think about, I guess, embryologically speaking, why does one have two and why does the other one have three lobes? On the left-hand side, an interesting point is that there's a little out pouch called the lingula. It's a tongue-like projection only found in the left lung. And if you have, it's not labeled on this diagram, but it should be this little bit here. Really, if you think about it, it's a middle lobe that's been slightly underdeveloped. Okay. And I guess the reason why it's underdeveloped is because it can't push against the heart and force it somewhere else, right? The heart needs to be there. So it kind of just stops developing in that region. Right lung, though, has no issues developing that middle lobe. You should also think about the fissures themselves that separate out the lobes. And it can be a bit annoying to think about, oh, what does the horizontal fissure actually separate? What does the oblique fissure separate? Because it'll be different depending on whether it's left or right. The easiest way to remember this is that the horizontal fissure will separate the superior lobe from the lobe that's below it. Okay, superior lobe from the one that's below it. And this is generally going to be at the fourth rib, whereas the oblique fissure separates the inferior lobe from the lobe that's above it. And this is only found on the right lung. So you can see oblique fissure on the right lung. Oblique fissure on the right lung, and you've got horizontal fissure here. Okay. The cool thing is that when you look at an X-ray, like a chest X-ray, it's really important to understand that anteriorly you will see like the three lobes, and you'll see the two lobes on the left-hand side. But when you look posteriorly, you will only see two lobes. And it's kind of just because that middle lobe, as you can see, it sort of tapers off and then it will end once it gets to the back. So that's really, really important when you're trying to figure out, when you see an X-ray and you look at areas of consolidation, so things that seem to be a bit more hyperdense than other parts of the lung, which should all be black because it's air. It's your job to localize which lobe is the consolidation happening in, if it's only, contained within a single lobe. Okay, so really, really important that you don't confuse middle lobes with inferior lobes when it comes to the right lung. But you'll have more of this in imaging, so I'm not going to labor onto it too much. Now, the structure of the hilum. So unfortunately, I'll have to say, you just have to memorize this. It's really, really important because when you get to dissections, when they give you a picture of a hilum, it's a good skill to be able to figure out which of these is going to be the left lung and which is going to be the right lung, because again, they're not symmetrical. And I guess you could also just think about what would be going into each of these hilums. So like, what does the lung need? It needs air, so that's going to be through the bronchi. It also needs vascular supply, so that's the arteries and the veins, which you can see nicely labeled here. Really, really important to remember that when it comes to the lungs, you have to remember that the definition of arteries and veins is sort of slightly different to when it comes to systemic circulation. So generally speaking, just remember that veins will be taking blood back to the heart. So in the case of the lungs, that's going to be oxygenated blood, which is why over here, it's actually portrayed as red. So red meaning oxygenated, but that doesn't mean it's an artery, it's actually a vein. In a similar way, blue is going to be things that are deoxygenated, but those are arteries, right? They're taking blood back to the lungs to be oxygenated again. Okay, so really make sure you understand and keep that in mind from cardiovascular last year. So they're located on the medial side. When it comes to just a couple of definitions, remember that the hilum represents like the actual structures, whereas, oh, sorry, the hilum is the whole thing, whereas the contents represent the stuff that's going through. Hopefully that makes sense. So the contents I said were the pulmonary artery, the veins, the bronchus. You got a couple of nerves and lymphatics, which are not important for actually figuring out which one is left or right. On the right hilum, in general, the main bronchus is posterior, and the same with the left hilum. They will both be the most posterior structures. Where it differs is the vascular supply. So with the right hilum, the vein is more inferior. And I guess you can see that here, when you can see the vein being a little bit lower down. Same on this side, you've got vein being a bit lower down. Whereas on the left hilum, it is antero-inferior. So yes, it's still inferior, but it's, I guess, pushed a bit more anteriorly. When it comes to the right hilum, the artery is more anterior, whereas in the left hilum, the artery is more superior. So have a look at the blue. You've got the artery being more up the front, whereas over here, you've got the artery being more at the top. So that's a really good way to differentiate them. However, I was never good at memorizing these things. And even like saying it right now, it's very difficult for me to figure out where things go. So the way that I like to do this is that I just use a 3-step rule, and 99% of the time you'll be able to figure out what's happening, and you'll look really smart to your lecturers and your tutorial teachers. So the first thing you're thinking about is the bronchus. As I already said, it doesn't matter if it's the left or right, they will always be posterior. And an additional thing you can think about is that they're also going to be closely associated with the artery. Not important really for now. So just remember, always posterior. You can see the yellow bit, right? It's always at the back, and this one is always at the back. With the arteries, just remember the mnemonic RALS, R-A-L-S. So on the right side, the artery is going to be anterior to the bronchus. So have a look at this. So you've got the bronchus here, anterior to it. So on the left-hand side, that's anterior for that lung. You can see the blue. Okay, that represents the artery. When it comes to the left side, it's going to be superior to the bronchus. And again, you can see you got yellow bronchus, and above it, you've got the blue, and it's superior. Okay, so that's really easy. And vein is going to be whatever's remaining, but it's generally always going to be the most inferior and anterior structure. Now, just really quickly to avoid any confusion, you'll notice that on both lungs, we've got sort of 2 sets of like veins that you can see, pulmonary veins. And that's normal. Remember that the pulmonary veins are sort of paired. It'll also depend on where you actually dissect the hilum. So you might, if you dissect it a little bit, I guess like medially, you might only see one set of veins, but then if you dissect more laterally, you might see more of those branching happening. So it does depend. But in general, these 3 rules and these 3 steps will get you the answer almost all the time. And remember that this is a nice opportunity for me to show you the pulmonary ligament. So this little fibrous tissue bit here, that's exactly where we'll actually get the pleural reflecting. So the parietal going into visceral, visceral going into parietal. Okay, now the tracheobronchial tree. Sounds like a mouthful, but it's really just describing the airways. And there's a lot of branching that's involved to get from your mouth to down into your lungs, where all the actual diffusion of oxygen and carbon dioxide happens. So the main thing to understand conceptually is that these airways keep bifurcating all the way from the trachea up here, which is continuous with the larynx, and then your mouth up here, all the way down to the alveoli, which is where diffusion happens. So just general points for you to really think about. You'll cover this more in histology when you want to differentiate between each of these parts. But the easiest thing to think about is, okay, you've got the larynx and trachea. You only have one of each. So with the trachea itself, you have a cricoid cartilage, which you can sort of see up here. And at the sternal angle, which is here, that's where it splits. So that's where it bifurcates into the right main bronchus, left main bronchus. And all of this trachea is held open by C-shaped cartilage rings. So they're not continuous around the whole thing. You will see the cartilages at the front. If I showed you a posterior view, you will see that they don't meet up at the other side. And there's also this really, really minor muscle known as trachealis, which helps to keep it patent. It's really important. You don't want the trachea to just collapse. You want these cartilage supports to be there. With the main bronchi on the left and right-hand side, you can see here in purple, they pass inferolaterally to the lung, so behind it, and they go laterally into the lung. But unlike the trachea, they're surrounded by complete cartilage rings. Not really sure what the reason is. Perhaps just because it's a smaller airway, it's more at risk of becoming obstructed. So you want, I guess, stronger reinforcement to ensure it doesn't do that. But I'm sure you can search that up and figure out what the reasoning behind it is. From there, you've got the branching bronchi. So you can see in the yellow and the green, I kind of put them together, but there's actually two categories of them. They're supported by crescent-shaped cartilages, similar to what was happening with the trachea. You've got the lobar, which is the first, they're called the secondary bronchi. They supply each lobe of the lung. So whether it's the superior, inferior, middle, whatever it is, they're going to supply those. So that's the ones in the yellow. And then those will branch off into the green, which is going to be the tertiary or segmental bronchi. And these supply the bronchopulmonary segments, which I'll show you in the next slide. Not really that important to know, but just know that as you keep branching, it becomes more and more specific which part of the lung you're actually going to be supplying with oxygen. So that's very important. Also important is to realize that at this stage, there is no gas exchange happening at all. So you're still just getting, these are still conduits. They're still called conducting airways. So they're just taking oxygen, they're delivering it. Once you get down to the bronchioles, that's where things actually start to get interesting. So that's not really shown here. I guess in orange, they've got subsegmental bronchi, which is not really a universally used terminology. But after this, you will start to get the bronchioles. So the tertiary bronchi branch into the conducting bronchioles, still no gas exchange. Then you get to the terminal bronchioles. After that, the respiratory bronchioles start happening. That's where we get oxygen exchange. Then from everything there, you've got the alveolar ducts, alveolar sacs, and then eventually, in total, you will end up with 300 million alveoli, at which quite a lot of gas exchange will be happening. And this will be the focus more in physiology. So anatomically speaking, there's not much you need to know about this microscopic detail. Now, just a question to think about, and I'll go into the answer really, really soon. But just if you want to pause and think about the question at the bottom. So it's saying, notice how the right bronchus, if you have a look here, it's a lot more vertical than the left bronchus. There's a reason for it. And if you can think of that, that's fantastic anatomically as well. But if you think about lung aspiration, so yeah, whether it's like I've vomited and the vomitus is going back inside, or there's actually been some sort of foreign body that's come into my trachea, which of these bronchi is it most likely to go into? Is it going to be the left bronchus or the right bronchus? So I encourage you to pause and think about it. Now, assume you've had a think. So the answer here is actually going to be the right bronchus. Before I go into why, just remember, or just to think about why is the left main bronchus less vertical? And the reason why is because you've got the heart here, right? Nested just underneath the left main bronchus. So the bronchus on the left-hand side cannot be vertical. Otherwise, it would go into the heart. The right main bronchus, because it's so vertical, gravity is going to have a much easier time pulling it down this angle. This is a sharper angle, so it's not unlikely to be able to go through. So when I talk to you about aspiration a little bit later on in this slide deck, have a think about which lung is going to be the commonest place that we will see some of those aspirated materials in. Okay, awesome. Now, bronchopulmonary segments, super duper 100% low yield. It's just for your interest to know about. I guess if you're going to specialize in lung stuff, then maybe this will be something you go into more details in. But for now, you just need to know that bronchopulmonary segments, as it said here, are sections of the lung supplied and innervated independently from each other. And they're separated by connective tissue layers. So you can see on this nice diagram, you can see that they've color-coded all the segments. And you can also see that they've, in a similar way, color-coded the actual airway structures that are supplying those segments. So these would be the tertiary bronchi that are supplying those segments. Why is it important that it's independent? Well, if I have a consolidation or a problem in this little red segment here, then what I can do is I can get rid of that segment, and the rest of the lung will still be able to work fine because they're supplied still by some sort of vascular structure. They're being drained by a vascular structure that's independent, and they also have an independent airway supply. So they're all going to work well. And just for your interest again, the air supply is going to be generally from the segmental or secondary bronchi, also the tertiary bronchi. The arterial supply will be from the tertiary branch of the pulmonary artery. Venous drainage is the intersegmental parts of the pulmonary veins. There's just a bunch of words. You don't really need to know these. What you do need to know is the arteries, veins, lymph, and nerve supply / drainage of the lungs. This should all just be revision from cardiovascular stuff. So I put a diagram showing you both of them together. You've got the lungs, you've got what's supplying the lungs, which is going to be the different parts of the heart. Remember that the heart is kind of called the right-sided circulation. So it's going to be supplied through the right ventricle. And then once everything is oxygenated in the lungs, it'll drain back into the left atrium. So the arterial supply, super straightforward. You got your right ventricle. It's portrayed as blue here because it's deoxygenated. Goes up to the pulmonary trunk over here, which is demonstrated in a purple color. Bifurcates at the sternal angle into left and right. Arteries, lobar arteries, segmental arteries, and so on until you supply the parenchyma. Venous drainage wise, you've got the left and right superior and inferior pulmonary veins. So you can see those not really well, like these pink bits here, those are the veins. And if you follow the arrows along, that's going to be where they connect together to form the trunk. And then they come down into the left atrium, they go into the left ventricle, and then off to the systemic circulation. Just note that the veins don't necessarily always follow the same course as the arteries or main bronchi. So think about the arteries and the bronchi as being sort of friends. They're always going to be next to each other. The veins just kind of do their own thing. And I've got more details about that in the notes. It's really not important for you to know, but anatomically speaking, it can be somewhat significant. Nerves wise, we've already gone over this. You've got the parasympathetic innervation through the vagus nerve. So that's cranial nerve number 10. What it will do is contract the bronchial smooth muscles, vasodilate the blood vessels, and increase bronchial gland secretion. Sympathetic nerves will do the opposite. So that's from the trunks. You've got relaxing bronchial smooth muscles, vasoconstrict vessels, reduced secretions. Remember with sympathetic, really all the things that are going to be happening are to try and open up the airways and ensure maximum oxygen absorption, whereas parasympathetic doesn't really care about that. And then you got the visceral afferents. So the ones that are actually carrying through the more specific types of pain and temperature. So that's still the vagus nerve and sympathetic trunks. It's not quite the same fibers as the ones that I've already discussed. And you'll go over this more when you get to nerve-related things in head and neck, what the differentiation between these are. But just know that they travel through the pathways. It's just not the same nerves. And they're going back rather than back into the spinal cord rather than going from the cord to the organ. You've got the reflexive things like sensation, stretch, and you've got nociceptive like pain. Lymphatic drainage is perhaps the most high yield part of these two slides. And the reason why is because there's a lot of clinical correlates when it comes to the pathway of cancers as well as for infections of the lungs. So this diagram pretty much summarizes everything. If you want to just look at this, that's fine. You can also have a read here for some of the important things that I've taken out of the diagram. So you've got the subpleural plexus that drains into the visceral pleura, that drains the visceral pleura, and the lung parenchyma, while the deep plexus drains the bronchi and associated vessels. You won't see these here. There's like many of them, but they're kind of just within the tissue itself. From there, it gets more important. So those plexi, they drain into the bronchopulmonary nodes. So those are the ones highlighted in pink there. So they're right where the bronchi enter into the hilum. Then you've got them draining into the tracheobronchial nodes. That's in the center. Again, all these names describe exactly where they are. So at the place where the trachea becomes the bronchi. And this is also the place where you've got the tracheal bifurcation. We also call it the angle of carina when it comes to imaging. Why is that important? Well, if you've got widening or splaying of the carina, more than likely the reason is because those lymph nodes have become enlarged and they're causing those two arms or the two bronchi to kind of, the angle to increase a little bit more. That widening is quite indicative of the fact that there might be a cancer in those nodes. And then finally from there, super straightforward, they'll drain into the paratracheal nodes on either side, into the right and left bronchomediastinal trunks. On the right-hand side, they drain into the right duct, and on the left-hand side, they drain into the thoracic duct. After this point, it's not really important to know. The main thing is just the bronchopulmonary nodes and the tracheobronchial nodes, because that's where the clinical correlates will lie. Okay, speaking of the clinical correlates, there's kind of only 2 or 3 things I want to go over. You'll cover a couple, maybe extra things during your anatomy tutorials, and that's kind of just icing on top of the cake. But these are the main things that you really want to know well to do well in the exams, as well as to do well in your clinical life. So I've spoken about penetrating injuries quite a bit already. And these are going to be specifically in 4 vulnerable regions around the thoracic cage where the lungs are a bit more exposed than everywhere else. So most of the time, your ribs and everything like that, they're kind of designed to protect those major mediastinal structures. But if you have a look at this diagram up here, you might, or this diagram as well here, you might notice that superiorly, the apex of the lungs, those kind of shoot up a little bit more. I'm sorry, I apologize for the fact that this diagram is quite small, but you can see that they shoot up above the clavicle and the first rib. And so if I have a stabbing injury up here or up here, then that can be significant damage to the apex of both of these lungs. So that's important. So that's 2 of them, those 2 vulnerable areas. Inferiorly, it kind of gets a bit confusing. On the right-hand side, you've got the infrasternal angle. So infrasternal angle, and on both the left and right-hand side, you've got the costovertebral angles. So infrasternal angle describes this bit here, and that's again just a place where you've got separation between the lung versus the parietal pleura surrounding it. So that can be a place where you can get injury. It's not important to know the specific landmarks at which that occurs, just know the name. And then you've got the costovertebral angle. So right at the back here, where you've got the 12th rib or the rib cage ending, and you've got the angle between that and the spine, that's where you can also have injury occurring. So this can be the lungs. It can also be a place where you can injure the kidneys. Airway aspiration wise, a couple of these are just buzzwords. Like we already know that when it comes to aspiration, the main place that it'll go to is going to be the right-hand side because it's more vertical. It's also shorter, so it's easier for it to get quite deep. However, the gravity and the position of the patient that you're seeing will also determine specifically where the aspiration happens. So I've put a little diagram here just to show you what some of these words mean. But honestly, as long as you can memorize these 3 things, it's totally fine. So if you're sitting up, then it's going to be the posterior basal segment of the right lower lobe. So I guess that makes sense because you're sitting up, gravity is going to pull it down to the lower lobe, and it's specifically the posterior basal part. If you're supine, so you're lying down on your back, it's going to be the superior segment of the right lower lobe. And if you're laying on your right, so again, it's going to go to the right, but if you're laying on your right-hand side, you got the posterior segment of the right upper lobe. So really, as long as you can remember that it's the right lower lobe, right lower lobe, right upper lobe, that's cool. And these are just extra points if you want to figure out where the specific segment at which those aspirates will get stuck. Lastly, you've got pneumothorax. So pneumothorax meaning air within the pleural cavity. There's 4 main types that we kind of have discussed. So you've got the closed pneumothorax, and I guess these diagrams are really good just to visualize them. So you've got a tear in the lung itself, and so air enters into the pleural space from the lung. So lung deflates because air is escaping from it into here. Everything else is generally normal. In an open pneumothorax, you kind of have the opposite. So you've got a tear in the parietal peritoneum. So you've just been stabbed right in the rib cage between the 2 ribs, and air actually comes from outside into that pleural cavity. You still got deflating of the lung happening just because this air is taking up so much space that the lung can't physically fill up with as much oxygen as it previously could. Tension pneumothorax is a really concerning one. So it's the same as an open pneumothorax, but what happens is that in an open pneumothorax, you can have air going both ways. So at some point, you will have some sort of equilibrium happening where things stop. But with tension pneumothorax, you have some sort of flap or one-way valve occurring. So air can only go in and it cannot escape. In that sense, you won't have an equilibrium happening and air will just keep coming in as much as it can. Why is that bad? Well, you're going to get compression of some of the mediastinal structures, so specifically the heart, and everything that's in the mediastinum will be pushed to the opposite side. So you can see the trachea, the airways moving to the contralateral side. You can see the other lung also becoming quite deflated because of the fact that it has less space to work with. And you've also got the arteries and veins being obstructed. So really not a good situation to be in. Spontaneous pneumothorax is just another buzzword type thing. If you know that a patient has a connective tissue disorder, so typically Marfan syndrome or something like that, there's no actual event that is required for a pneumothorax to happen. It will just happen automatically because the connective tissue is already quite weak. The main complication of a pneumothorax is lung collapse because you've got increased pressure in the intrapleural space. Specifically in tension pneumothorax, as I said, everything shifts to the other side, including the heart and other structures that I've mentioned. How do you manage these? Well, it's the reason why we went over those surface landmarks is because you can literally save lives by knowing exactly where to put your needles. Also, how not to kill someone, because you know that you're not supposed to put your needles in some places because you're going to puncture the lungs. So needle thoracocentesis, that's for rapid decompression of tension pneumothorax. It's a temporary fix, so you still need something a bit more solid afterwards, which is the intercostal catheter. But the main place you're going to do this is going to be the second intercostal space mid-clavicular line. So you can try and feel for that, where that might be on your body. So second intercostal space, if you can feel your sternal angle, it's just going to be that area, mid-clavicular line. So it's going to be around here and here that you have the needle going into. So that can easily get rid of some of the air or fluid. And then you can get the intercostal catheter for everything else. So as if you want to get rid of the air, blood, or fluid as a long-term solution. So that's going to be inserted into the fifth intercostal space, just anterior to the mid-axillary line. So it's kind of called the triangle of safety, if you see it in textbooks. There's a couple of landmarks. You don't need to memorize this, just know generally where it is. But it's going to be around here that you can insert your needle. So you raise your arm, insert needle there, and then you can drain whatever's inside. I should mention that, so pneumothorax, I said it was air. You've also got other things that can build up within this space. So if it's not air, if it's just like fluid or water, that's a pleural effusion. If you've got blood, then it's a hemothorax. With the fluid, so the just water and blood, the findings are going to be very much the same. The main thing you need to know is the blunting of the costophrenic or costodiaphragmatic angle, which I've shown here. So pleural effusion is fluid. You've got blunting of the costophrenic angles. As you can see on this X-ray, it's quite an extreme version. So you probably might not see something as extreme as this, but you can see on the left lung here, everything looks normal. You can see that angle is really sharp and visible. Whereas on this side, that angle is just completely disappeared. Like there's nothing there. And also this is the air, right? The black is the air. All this white stuff is potentially fluid. So that is highly indicative of a pleural effusion. Generally happens because the lungs are either secreting too much fluid or not absorbing enough of it. There can also be other conditions like pneumonia, heart failure, you would have learned about last year, tuberculosis, and pulmonary embolisms that lead to fluid development, as well as some cancers. Generally, when you are doing an examination, you will hear only unilateral expansion because the other side is just so filled with water, you can't hear much. Dull percussion, so when you do the percussion with your fingers, generally fluid is dull, whereas the air is tympanic. And you might hear squeaking noises on auscultation because of the fluid. I already talked about the costophrenic angle. And remember back to your studies about the thorax last year. Remember that when you want to sample fluid via thoracocentesis or pleural tap, you need to ensure that you are working between the two ribs, but not going into the superior part of that space, because you are likely to damage the nerve, potentially the artery that runs underneath the rib. So you want to go aim for the middle, and if not, you can go lower down because you're likely to only damage the collateral branches. It's important to remember some of these buzzwords as well, just to figure out where do I need to put a pleural tap. The reason why it's important to remember this is because it depends on how high the fluid level is. So in this patient, it's come up to maybe the inferior lobe, but it can go even higher than that, up to the apex. So generally, you want to insert the needle in either the mid-scapular or mid-axillary line. In this case, it's the mid-axillary line, I think, that they put it in here. One or two intercostal spaces below the highest level of pleural effusion. And you can be fairly certain that you're not going to hit the lung just because you've got all this fluid that's in there, and you will feel it when you put the needle inside. You should also try and insert it below the lungs in the costodiaphragmatic recesses. So places where, as we mentioned before, the lung doesn't fully fill up the thoracic cage. So you've got between 6 and 8 for the MCL, 8 and 10 for the MAL, and 10 and 12 for the MSL. So the space between the visceral and parietal pleura, essentially. And that's pretty much it. So thank you for listening. Please let me know either privately or during one of our sessions that we have together, whether you have any questions about this specifically, or you'd like me to cover one or two more clinical situations. But I hope you enjoyed that lecture, and best of luck for your studies.